Welcome to the Women's Health Podcast. I'm Marika Hart from Hemisphere.
And I'm Anthony Lowe, the physio detective. Together we interview leading authorities, answer questions, and share our thoughts to provide the general public with the best quality information we can find on all aspects of women's health. Please remember the materials and content on this podcast are intended as general information and for entertainment purposes only.
They are not intended to be a substitute for professional medical advice, diagnosis, or treatment. Now it's time to get cracking with the episode. So whether you're out walking your dog, driving the kids to school, or just sitting back enjoying a glass of wine, we hope you enjoy the show.
Hey everybody, welcome back to the podcast, and we've got Carolyn Vandyken here with us. As our guest today, we'll be talking about pelvic pain, but as usual, my co-seat, the co-driver, the inspiration, the triple threat, Marika Hart, welcome back.
I feel like my intro is getting longer at every episode. Thank you, Anthony.
I'm trying.
Oh, you're hilarious. Thank you very much, and it's very nice to speak to you. And today we've got Carolyn Vandyken all the way from eastern Canada. Welcome to the show, Carolyn. It's so exciting to have you here.
Thank you for having me. I'm really excited to be here with both of you.
And it's really funny because I told some of my colleagues that I was interviewing Carolyn, and they completely fangirled and were like, "Oh my God, you're interviewing! She's so amazing! I'm so excited!" So I'm even more thrilled now. And so for those that don't know Carolyn is a physiotherapist. She's an educator, she's a researcher, and she does a lot of work in the areas of low back pain and pelvic pain and pain science. So you're not going to find her arguing on Facebook and messing around on Instagram too much, because she's very busy at work doing a lot of things, and doing a lot of educational courses online as well. But you know, in a nutshell, she's been working as a physiotherapist for 33 years, and she's really, really passionate about helping therapists get out of their individual silos, so sitting in our little groups of musculoskeletal physios or sports physios or pelvic physios, and working together and really trying to integrate that biopsychosocial perspective in terms of supporting people with pain. So her research is very much looking at connecting those areas of pelvic health and low back pain, which are two things that I work in a lot. So I am really, really excited to learn more from you, and I'm just putting that lightly, but yeah, I'm really, really excited. So welcome, Carolyn.
Thank you so much, Marika. And I don't know, that might have rivaled Anthony's introduction of you. So thank you so much.
No, it's always a pleasure to have people like yourself on, Carolyn. And I remember, you reaching out to me and asking if I could bring my female athlete course to Canada, and I'm really grateful for the start that you gave me in Canada and coming on that course. And I knew that you're involved with pain science and friends with Sandy Hilton, and I'm like, but it was a fun course, and so you and Nellie really facilitating that was really helpful, so thank you for that. And recently I did your online pain course, which I can recommend, as it's designed for therapists, and it's fantastic. I really got a lot out of it, and hopefully we'll be talking about some of the things that pelvic PTs can be looking at. So if you are a pelvic PT, or if you have a pelvic PT, you can discuss some of the things that we're going to talk about on this podcast. So yeah, thank you very much, and I look forward to. I'm going to be in Toronto later this year again, so who knows?
We'll have to get together.
That'll be fantastic.
When you're here, yeah, sounds great. It was very inspirational, actually, the very first time you came to teach, to really kind of look at prolapse and the female athlete from a very different perspective than we've done in Canada before. And so it's really cool, I think, to bring some cross-cultural, cross-international information together. And I think that has really caused us all to grow and challenge what we think and do. So thank you as well.
Thank you. Really appreciate that.
So Carolyn, we'll just jump into our first question, which is really, we always like to find out more about our guests and their story. So how you came to be working in this area, and if you would like to share that would be wonderful.
Okay. So, as you had indicated, I've been a physio for 33 years, and most of my career actually I have spent in musculoskeletal physiotherapy. It was in the late 90s that I credentialed as a McKenzie therapist, and so I did all my short manual courses earlier on in my career. Stumbled across McKenzie. It really spoke to me. I liked the self-efficacy piece. And I really enjoyed the clinical reasoning piece of the McKenzie approach. And so that's really how I started in low back pain. And so I treated predominantly low back pain and neck pain for probably close to a decade. And then it was really in 2001 when I struggled with my own stress incontinence at about the age of 35 after having 3 kids that I stumbled into pelvic health. And how that happened was I had returned back to Southern Ontario. We had been living in the far north. Now we're living kind of in the mid-north at this point. But I went back to Southern Ontario and I started to play basketball again. And as I played basketball, I realized very shortly at the age of 35, I could make about 2 trips up and down the floor without having to go change my pad. I had significant stress incontinence. And so I thought, I'm a physio. I need to figure this out. And so I registered for the pelvic health course here. So this was 2001. Pelvic health was not very popular in Canada at that point. And so there was one course being held in Toronto. There was 8 physios on the course, and I registered. I got to the course, and I hadn't read the fine print on the course brochure very well that said, we're going to be doing internal exams on each other. And so I got to the course and I went, oh, that's interesting. Anyways, I thought, I'm here, I'm incontinent, I need to figure this out. What the heck? So away I went, took the course. By the 3rd day of the course, I had a wonderful instructor, and she really has been my mentor through pelvic health, and her name is Marie-Josée Lourdes from Montreal. And so I was brave enough on the 3rd day of the course to volunteer to be the model for the STIM lab. And so I hop up on the table and 8 physios gather around, and Marie-Josée inserts a vaginal probe and turns on the current, and my pelvic floor contracts for the first time in about 10 years. Now, I'd been doing Kegels. I thought I was doing Kegels, but clearly I was not doing Kegels correctly. And so I walked away from that course thinking, I'm a physio, I'm an athlete, I've got pretty good kinesthetic awareness. I had no clue after having 3 babies where my pelvic floor was, how many women are really struggling. And so that's really what started me in pelvic health. And it wasn't really until probably 2006 where I took a course with Rhonda Cotterinos on pelvic pain, where we first heard the term overactive pelvic floor. So she was one of the first physios, almost a decade and a half ago, to start talking about pelvic pain versus just incontinence. And that really is what started me down the road of pelvic pain. And then it was 2008 that I took a course from another one of my mentors, Debbie Patterson, who is a wonderful pain science physiotherapist here in Calgary, Canada. And she really turned me on to pain science. And then it was 2010 that I met Sandy Hilton at the Nottingham first neurodynamic and neuromatrix conference that Butler and Mosley put on. And it was really at that conference where I started to think, wow, how do we apply central sensitization and some of these concepts to pelvic pain? Because, at that point, they were really talking about graded motor imagery and laterality. And the joke was, where do you put the mirror in pelvic pain? Like, how does that work, right? And so both Sandy and I actually went up to David at that first conference in 2010 and said, how do we apply this to pelvic pain? And David literally said, how the hell do I know? Go and figure it out, right? And so Sandy and I sort of got together after that and started to apply the concepts to pelvic health, leaving the mirrors alone at that point. So that's kind of my journey into pelvic health. I have an MSK background, and I'm very, very interested in biopsychosocial approach and central sensitization.
Wow, that's quite a story. I've got so many questions in my head about that. But well, there's nothing new there. But it's interesting. So just for the people that aren't sure at home, pelvic pain, can you describe pelvic pain in the context of pelvic health, and what that is, what it might look like, what some of the symptoms might be, and, you know, what conditions
Okay.
they might be, please?
Okay. Yeah, great question, Anthony. I think one of the things we need to do is to stop separating pelvic pain from lumbar pain. I really prefer the term lumbopelvic pain because I don't know many patients who sort of suffer from pain in the pelvic area who also don't have lumbar pain, low back pain, pelvic girdle pain, hip pain, and vice versa. So I think one of the things we need to start recognizing is you know, as pelvic health therapists, or maybe as MSK therapists as well, we've kind of drawn this dotted line from the pubic symphysis to the sits bones and kind of said, well, that's pelvic pain. So, you know, pelvic pain really is defined as anything sort of from the pubic bone to the tailbone. Groin pain can also be designated as pelvic pain. Sometimes pelvic girdle pain, which is pain, you know, along the pelvic region to the SI joint, for example, can also be lumped into that. But what we see often with pelvic pain and pelvic health concerns is changes in the pelvic floor muscles. And when we see changes in the pelvic floor muscles, we know that there are two main problems. One is that the pelvic floor can be too tight, and the other is that the pelvic floor can be too weak. So when I was running down the basketball court at age 35, having to change my pad every second trip, I had incontinence, I had stress incontinence, and my pelvic floor was too weak. But for many people who are suffering with pelvic health issues, the majority of them actually have pelvic floor tension problems. And one of the reasons maybe is that the pelvic floor, the muscles between the pubic bone and the tailbone and the sits bones, are highly protective. And when we are emotionally stressed, anxious, any sort of high sort of psychosocial distress, one of the first muscles in our body to react is the pelvic floor. We guard with our pelvic floors. And intuitively, that makes sense, right? Procreation, sexual function, bladder function, bowel function, everything that's important in the world as far as survival of the species happens in the pelvic region. And so when these muscles get tight, we also get a lot of upregulation or sort of crosstalk or conditions that happen together with pelvic floor tension. And that is conditions like bladder pain syndrome, interstitial cystitis, endometriosis, irritable bowel syndrome. Any of the gut type of issues can be very related to too much tension in the pelvic floor. And all we really know at this point is that they happen together. We don't know, sort of chicken and the egg, what causes what, but we know that they are highly connected.
You did such a good job of summarizing something that's incredibly complex into a short space of time. Thank you. When we asked you what you love talking about, Carolyn, one of the things you said was the link between low back pain and pelvic pain, and obviously you alluded to that a little bit there. When you were working clinically with your patients, what were some of the things that made you kind of think, hang on, there's some lumbar spine involvement here. This is not purely pelvic floor? Or with your patients who are coming in for low back pain, what made you sort of think, this might be an overactive pelvic floor?
Right. Great question. So I think because I started really as an MSK therapist, I never stopped screening low back pain. Right. I started there. I was very comfortable. I had good skills in treating and assessing low back pain. And so pelvic pain came second. And so I never stopped looking at the lumbar spine. And so I've always seen that connection. It's not that I sort of stumbled across it at one point. And I think sometimes for pelvic health therapists who may have started more in pelvic health or really focused there earlier on in their career, they may miss that MSK piece just because that isn't something that they've typically looked at. So I think it's really important to remember that pelvic health or pelvic health rehab is really just orthopedics in a cave. It's just orthopedics. And I really failed to understand in 2020 how MSK therapists are not consistently integrating pelvic health principles into their day-to-day practice with hip pain, low back pain, pelvic girdle pain, and how pelvic health therapists are not integrating the whole person as well. And when we talk about the whole person, we also need to expand beyond that and think about the brain and the nervous system, because we talked about how protective the pelvic floor is. So I think it's really important, and I've been accused in the past of pathologizing or over pathologizing the pelvic floor. And I really had to take a good look at that and say, you know, am I doing that? Am I trying to make low back pain all about pelvic floor dysfunction or pelvic floor problems? And, you know, I don't think I am. I think maybe at one point, maybe even 4 or 5 years ago, I probably was. That was part of one of my thought processes in some of the research that we were doing. But I recognize now as well with a lot of the work that Peter O'Sullivan is doing, and Peter O'Sullivan is certainly one of my pain heroes for sure. I really like his work. I really think he's going in a direction that is a good direction for us clinically when treating low back pain and pelvic girdle pain. But we need to just recognize that the pelvic floor is a highly responsive region to stress. And when there's tension, it is very unlikely that there's tension because there's a pathological or a structural problem. There's tension because that is the brain's way of protecting that area, and we need to start looking centrally in the nervous system and in, you know, with the whole person's experience when we start talking about lumbopelvic pain. So there, I brought it right back around to central sensitization, didn't I? Which is, of course, what I also love to talk about.
It's just, I don't know what you think, Anthony. I've just found recently the patients that I get sent to me with a more typical sports injury, mus type problem that's actually had an underlying pelvic floor component, they don't tend to come to me for years. It's almost like it's the last thing that's tried. So they've, for instance, I had a young guy, he's only about 25, referred recently with scrotum pain, but he's had so many scans, injections, lots of sports physiotherapy. It was all, you know, pubic symphysis pain. And look, I'm not by any means dissing anyone who we saw along the process, because it very much presented like a sports type injury. But I've had a few clients like this, and it does seem to be that they've been sort of gone through all these different processes, and then it's at the last minute, it's like, oh, God, what else should we try? Oh, maybe we should try the pelvic health physio. So I do wonder whether there's a better way of going about this to screen a little bit earlier.
Yeah, I think that that's an interesting observation, and I have seen that for years in my practice actually as well. It's kind of like we're the last stop, right? We've tried everything else, go to pelvic health, instead of perhaps being the first stop when you screen for pelvic health problems. So one of the studies that we just published in 2019, so when I say we, I work with a team that's really led by Dr. Sinead Dufour at McMaster University, and my daughter Brittany also helps out on these research studies. So she graduated as a physio just a couple of years ago, and people like Marie-Josée Forget have also been really helpful in the research area. But what we did was we actually ran a study to see if we could help orthopedic therapists, so typical MSK therapists who aren't necessarily thinking about the pelvic floor, to screen for pelvic floor dysfunction. And based on a screening tool, could we actually help them identify whether overactivity is the main problem, weakness is the main problem, or a lack of coordination is the main problem? And so it was actually a negative trial, and despite that, we still got it published in a very good journal. And so basically what happened was that we could identify with 100% accuracy in a double-blind study, when people identify that they have a pelvic floor problem, a blinded physiotherapist who does an internal exam can also, with 100% accuracy, identify that there's a pelvic floor problem. So we know that, first of all, screening for pelvic floor dysfunction is a very accurate way of identifying pelvic floor dysfunction. So we know that much. So I think that MSK therapists need to start screening from the beginning. When you've got someone with groin pain or hip pain or low back pain or pelvic girdle pain, you need to start screening things like, do you have pain with intercourse? Are you chronically constipated? Do you have urinary leakage? Do you have fecal urgency or fecal leakage? Do you have pain with intercourse? Do you have painful periods? If we screened that from the beginning, with your male patient, we'd be screening as well for scrotal pain and penile pain. If that was identified from the beginning, then we can say with 100% accuracy that there's a pelvic floor issue here. What we were not able to do on that same study was then to be able to predict, based on the type of presentation they they had, whether they were overactive, tight, or weak. Okay, overactive, sorry, weak, or lack of coordination. And so the only things actually that were correlated is people who have urinary urgency and urge incontinence and central sensitization. Those were strongly correlated with an overactive pelvic floor. So we can at least start to as well screen using the central sensitization inventory if they have a pelvic floor complaint and they have low back pain and they have a CSI score greater than 40, so those are 3 N's, right? Then perhaps they need to start with the pelvic health therapist. Perhaps the first referral for that patient should actually be to a colleague who does pelvic health, if that's something that you don't do, right? Or perhaps even as MSK therapists, we need to start upskilling ourselves in understanding pelvic health conditions, and at least starting to understand, when we should be doing core strengthening, when we should stay away from core strengthening, because, these folks might have an overactive sort of system that is highly guarding and highly protective.
Yeah, it's I'm MSK Sports and External Assessment Women's Health, and it is something that I do ask, but I don't ask everybody, and it really just depends on that flow. It's still that awkwardness. I reckon I do okay up against most MSK and sports physios for pelvic health, and it's still difficult. In what ways do you think a therapist? So you've got the questions there. Do you have pain with intercourse, constipation, toileting issues? Are they the only screening questions that they should ask? What are some other signs, symptoms, even clinical things that you've seen that might be associated?
Carolyn, sorry, Anthony, just on that, just jump straight in. But for a lot of the musc physios who struggle with asking those questions, I mean, do you have like a screening tool that you say, look, here you go, can you just get every single person to fill this
100%. So at Pelvic Health Solutions, which is the teaching company that Nellie and I ran in Canada for the last 10 years for training pelvic health therapists, probably 8 years ago, we actually developed a screening tool for MSK therapists to screen low back and hip pain patients for the presence of pelvic floor dysfunction. And we've been teaching that for quite a while. But the study that we just published in Manual Therapy in 2019 actually validated that study or those questions and said, yes, they're accurate questions to pick up pelvic floor issues. And there was, again, that great correlation in a blinded assessment. So I would say just simply giving your patient a screening questionnaire is a great starting point, right? I mean, sometimes we're assessing people in a gym area, we don't necessarily have private offices, which can be then a barrier to asking some of these questions. Sometimes, again, Anthony, you might find this, sometimes it's a male-female thing, and it depends on kind of that relationship that you've developed, whether or not you're comfortable asking those questions, or so there are many reasons why it doesn't happen. I think mostly it doesn't happen because we're not comfortable, not because our patients aren't comfortable talking about it. That would be my experience.
Sorry, my microphone mute button wasn't working well there. Yeah, it's good to be able to have that, and hopefully, is that tool easily available? Can we put a link to it, or
absolutely?
We'll put them in the show notes for people so that they can see that.
I will send you that.
Yeah, it's been good to work in the area, and I took that course that I mentioned earlier with you, and just looking at some of the, we're talking about screening, just looking at some of the components of pelvic pain. It was a pelvic pain course that I took with you. Do you want to talk a little bit just about SAD cliffs and what SAD cliffs are, and how that relates to a pain presentation for somebody who's got pelvic pain, please?
Okay, great question. And I have to thank Anthony for helping me to come up with that mnemonic, first of all. So that was in great part his idea, which has been really fantastic. So I think really my time spent in pelvic health and pelvic pain has really reinforced the need for me to develop my skills in central sensitization. Because if you look at, so Clifford Wolf is a physician researcher who has done the lion's share of work over the last 30 years, really initially on central sensitization, which is really just what happens in central sensitization is that the central nervous system, so the spinal cord and the brain, basically act as an alarm system. So when there's a danger message or a threat that comes from your tissues to your spinal cord can actually decide whether or not to heighten the value of that threat, make it even more, ring the alarm bells quicker and move that message quicker to the brain, or to dampen it down and slow down that message. And in a sensitive nervous system, those danger messages get hyperexcited and push through to the brain much quicker. And then the brain also physically changes so that it is more likely to produce a pain response even when the messages coming from the tissues are non-threatening. Okay. And so in pelvic pain, what we know is that almost every pelvic pain condition is on Clifford Wolf's hit list of what is dominated by central sensitization or central pain mechanisms. So irritable bowel syndrome, interstitial cystitis, bladder pain syndrome, chronic prostatitis in men, non-bacterial chronic prostatitis, endometriosis, dysmenorrhea, idiopathic low back pain. All of those conditions are dominated by central pain mechanisms or this hypersensitive central nervous system. And so I really couldn't spend time in pelvic pain without really coming against this on a regular basis. And then I was lucky enough, again, about a decade and a bit ago, to have some really great exposure to some clinicians who were very skilled already early on in assessing and treating central sensitization. And again, Debbie Patterson was one of those physiotherapists. And I learned from her quite quickly that what we need to do is we really need to not just identify central sensitization, but we need to be able to identify why that individual's nervous system is sensitive. And again, in pain, what we know is that our sample sizes for pain research is really one, right? Every person is individual in their pain expression. We don't have two pain stories that are the same. And so what we need to really do is use a very broad sort of approach to treat and assess persistent pain. And we call that a biopsychosocial approach. So a bio means just looking at the tissues, because sometimes the tissues are still irritable or still stiff or still weak, and that may be contributing to the pain. The psychosocial pieces are where SAD cliffs come in. So SAD cliffs are a mnemonic for the different phenotypes or the different types of sensitization that can occur in each individual. And by identifying them, it allows us as clinicians to start to address those specific targets. So S in SADCLIF stands for stress, and then it goes stress, anxiety, depression. And so we need to measure with each of our patients how much self-reported stress, anxiety, and depression they have. Catastrophization is another big one, so that's the beginning of cliffs. Catastrophization is normal. We all catastrophize when something happens. So if I'm flying to San Diego next week to do some teaching, and if on my way to the airport, I get into a fender bender, the first thing I'm going to start to do is to catastrophize. How am I going to get to the airport? I'm going to miss my plane. I have to teach the next day. You know, maybe I have some soft tissue injuries. I mean, catastrophization serves a purpose. It gets us social assistance. So I'm going to call my husband. He's going to help me problem solve. Maybe, you know, my sister's going to meet me at the airport. And so catastrophization has a role. But when we get stuck in catastrophization, it's highly predictive of people who get stuck in this persistent pain loop. Okay, so that's catastrophization. The first L, there's two L's in SADCLIFs. The first L stands for low self-efficacy. And again, low self-efficacy is someone who is not confident that they can continue with their meaningful activities in life despite their pain. And so that also affects how we treat that individual. If they have low self-efficacy as MSK therapists and as manual therapists, those are probably the patients we don't want to do a lot of passive treatment with. We want to really get them moving actively and get them engaged in their own rehab so that we build their self-efficacy up again. And the second L stands for low positive affect. So we know when we have low positive affect, the immune system is suppressed, and pain is a neuroimmune response, right? It's the neuroimmune system that produces that overprotection. And then I is injustice. We see a lot of injustice in pelvic pain, in sexual trauma. We see a lot of injustice in motor vehicle accidents. We see a lot of injustice. F of SADCLIF stands for fear, or fear avoidance, and fear is a big driver as well. We see a lot of fear in our offices. I think that that's a pretty common finding that we see. And that's where Peter O'Sullivan is starting to come in again with developing some cognitive functional therapy approaches to deal with fear. And then there's two S's at the end of SADCLIFs. The first one is shame, and shame is again very prevalent in our pelvic pain population. We are asking our patients to be very vulnerable with us when we do pelvic exams, and we will often pick up a lot of shame. And shame really means, shame is not I did something bad, shame is I am bad, right? And if there's that intuitive sense of I am bad, I am wrong, and the brain's job is to protect us, and the brain's job is survival, you can see that. There was a really interesting study done in 2001 by Vandervelde. If you show women, now the study's never been done on men, but we don't really expect men to be any different, but if you show women very frightening film and you put muscle sensors over her body, before she blinks or moves away, her pelvic floor tightens. So we're hardwired to protect the area of sexual function, bladder function, bowel function, procreation, right? And so you can imagine that if there's been some trauma, or if there's been something that has really negatively impacted that person, and shame is part of that, that tension or guarding can also happen in the pelvic floor. And then the last one is smudging or sensory motor changes. And that can also be a big driver of a sensitive nervous system. And again, I'm going to give a shout out to Ben Wand and his group in Australia as well. I think he's in Western Australia, if I'm right. Is he close? Is he in Curtin? Is he at Curtin University? No.
God, I know the name. I don't know where he
Ben
is.
Wand? Yeah, I think he's out in your neck of the woods. But anyways, he's done great work in validating sensory motor smudging using the Fremantle questionnaire. So he's in Fremantle. Is that
I'm a Fremantle Dockers fan.
Oh,
so
there you go. There you go. So that's SADCLIF. So SADCLIF really just gives us a picture into the nervous system of the person in front of us to help us sort out what we may need to address, and then also helps us to measure again, if we do, let's say if someone is struggling with depression, we know that exercise is a very important component in helping people manage depression. So it could be resisted exercise, and Anthony Lowe's expertise in that area can be really helpful. It can be yoga, that's really helpful, or just can be cardiovascular exercise. So whatever you choose with that patient to do, if you've got this measurement that they're moderately depressed, then after engaging in those types of activities for about a month or 6 weeks, we want to remeasure again. So it really is a way of predicting who might benefit from what type of intervention. And it's very helpful. I've been using it in my practice for the last maybe 5 or 8 years. And it makes me my treatment plans are much more succinct, and I would say quicker and more effective with my patients because I use that type of approach.
Thanks, Carolyn. It's really important for us, we were all trained to focus on the issue in the tissues, as they say. What's wrong with the muscle? What's wrong with the joint? What's wrong with the ligament? Part of my early social media experience has been helping people with SI pain. And how do you help people understand, looking at these things, lots of people often push back and say, do you think it's in my head? Do you think, are you saying that I don't really have an injury, even though the scans don't show anything. And I'm thinking of SI pain at the moment.
Mm-hmm. Mm-hmm.
Or, you know, it's called SI joint dysfunction.
Mm-hmm.
And like, what does that really mean? How
Right.
do
Right.
you, you know, can we use that as an
Mm.
example of sad cliffs, because that might help with the musculoskeletal and the pelvic health side of things. You know, the SI is often a nice
Mm.
crossing
Mm-hmm.
bridge,
Mm-hmm.
literally and figuratively.
Yeah.
um,
Great question. So I would say that first of all, there's some good. There's a new study that was just published, and the author is not coming to the top of my head. I want to say it was even 2020, but maybe late 2019, that looked at the biomechanics of the SI joint very critically to say there really is no such thing as SIJ dysfunction. Like that is a terminology that we maybe need to re-examine as physiotherapists, because the SI joint doesn't move enough to be dysfunctional. So there's an argument to be made around that piece. So let's talk about SI joint pain. So if someone came to me with SI joint pain, first of all, I think the most important thing is to really take a thorough history. And that really means something very different to me today than it did probably 10 years ago in my career. 10 years ago in my career, it was like, take a very short, pointed, direct questioning kind of history, ask yes, no questions that could be answered with yes, no, right? No open-ended. You want to get through what makes you better, what makes you, like, just very specific questions, right? And anytime they went off on a tangent, you try and steer them back so that, again, you get that subjective history down to about 10 or 15 minutes. And now you can get your hands on your patients, you can get them moving, and you can determine based on a good physical exam what's going on, right? That's how we've been trained at as MSK therapists. And in the last 10 years, really, in developing my skills in persistent pain, I very much start with, again, quite an extensive questionnaire. And then I really just put the questionnaire down and I say to my patients, I really want to just hear your story. Can you just start from the beginning and tell me what you think I need to hear? I've got all this stuff written down. It's great, but I want to hear in your own words what's going on. And now I'm starting to listen for their language. And I'm starting to listen for fear. And I'm starting to listen for anxiety. And I'm starting to, and your patients, our patients will often tell us that stress makes them worse, that when they're anxious, they have more pain. They often make those links for us so that we can then build on those links. But that means we first have to take the time to really listen, right? So in that, we know from good research as well that is what builds the strong therapeutic alliance. So first of all, doing that piece. And then when we take a biopsychosocial approach, what we know about the SI joint is you first have to rule out the low back, right? So don't miss the tissues. Rule out the low back, because low back pain can mimic SI joint pain, right? But SI joint pain will not, like, so if it is the pelvic girdle or the SI joint, we're not going to create back pain from that. So it doesn't go in that direction. It only goes sort of down that way. And so what I'll say is to patients, okay, we're going to rule out your low back. Now let's rule out the pelvic girdle. So what do we do to rule out the pelvic girdle? Well, we do our provocative signs. We do our active straight leg raise test. We do the signs that are the tests that we know we have some good evidence around. I don't do any mobility testing of the SI joint. I don't do the sort of kinesthetic tests, because again, we don't have good evidence around them. And I will then look for signs and symptoms that are consistent. So they have to have 3 out of 5 provocative tests for me to say with confidence that they have an SI joint problem. But now we also need to think about the pelvic floor, because if you have pelvic floor tension, you can also then create sort of provocative signs in the SI joint. That has been sort of my clinical experience. But I always start from the top down. So I always start with the spine, then I go to the pelvic girdle. If they have pelvic girdle pain, I really like Cecile Roos techniques. She's a Dutch physiotherapist who actually published in Spine in 2004, 2006. I like her techniques for pelvic girdle pain because they are very self-efficacious. They build skills within the patient. And then I will look at the pelvic floor. So that's the bio. But the psychosocial piece I have also done right from the beginning. So I don't turn in the direction of central sensitization once I've assessed and treated the tissues and I can't get anywhere with that. I actually start in a biopsychosocial perspective. So right from the beginning as well, I'm doing all those SADCLIF screening questionnaires and looking at the components of central sensitization that are presenting in that particular patient. And one of the things that the research is starting to show us is that in pelvic girdle pain, central sensitization is a very common sort of comorbid problem with pelvic girdle pain. So it's something we have to consider from the bottom, from the beginning. And so I think if you start in that way, instead of trying to treat it biomechanically, and then when you fail, then say, well, let's talk about your nervous system, you have a much better chance of actually getting your patient on board from the beginning. And I would say that the majority of my patients, when I start in that framework, really understand that I am not saying it's in their head. That is something I'm getting less and less of as I become more skilled in this area. And it is a skill set that we have to develop.
And I think we've all made that mistake clinically. I look back, I did a course with Mick Thacker. I don't know if you know Mick from...
Oh, yeah.
2000 and, I want to say 2003. It was a long time ago.
Okay.
And he just blows my mind. When I hear him speak. But anyway, I did this course and learning all about pain science. Next lady walks in through the door and I think, I'm going to pain science her. But I remember she came in with low back pain. She'd had it for 10 years and this is in the NHS. And I just cocked up so bad. And she just, the look that she gave me, she just said, you're saying it's all in my head. And I went, no. What I mean is, and then I was like trying to talk about the brain and the spinal cord, and she just gave me this look of disgust, and she walked out the door, and she never came back. And I remember at that time thinking, yeah, that was not done. Thankfully,
we've all done it.
We've all done it.
We've all done it. I can still remember talking about pelvic girdle pain. I had this 62-year-old man in my office once who came with a 3-year history of SI joint pain, who said he dislocated his SI joint standing up from a camping chair, right? And of course I had to say, let's just talk about that a little bit and break that down. And he's 62, he's a man, the likelihood of, and you can't dislocate your SI joint. And all he did was sit back in his chair, fold his arms, and look at me like I had 2 heads. And I knew at that point, Marika, I'd done this long enough that I thought, I need to stop right now, and I need to backtrack, and I need to find another way to get him on board, because this was not going to work, right? But it's interesting. When we talk about the SADCLIFs, I have so many physios and so many therapists say to me, patients don't want to fill out those questionnaires. The barrier for them is that they think patients really don't like the paperwork. And I'm going to challenge that comment with saying...
I've not had any problems with it.
Yeah, interesting, eh? So
it's just the receptionist to send it and it's done.
Right. And I would say most of my patients come in because I've sent them those questionnaires ahead of time. They are prepared to start talking about their pain from both a physical and an emotional perspective. And they're primed to do it, and they're happy to have that conversation because they've already made those links. They get that there's more going on than just what's in their tissues. I would say 90% of patients, that's true. There are some people that are just bent on figuring out, kind of what's wrong with their tissues, for sure. But that's in persistent pain. That I would say is the minority, not the majority. So
it goes back to seeing people as people, right? Not as an SI joint diagnosis, which obviously some people can take on as an identity, but people really do like that we treat them like people, and consider the whole thing, and that's what we've got to do everywhere in our lives. Thank you for clarifying that. With respect to what some of the pelvic health therapists might be doing, with respect to, I don't know, the world. I used to have a slide where there was a world, and I made it, animations in PowerPoint. I made it go around the pelvis because in my experience, particularly in the earlier days, I just thought pelvic health therapists thought the world revolved around the pelvic floor. In what ways can we get pelvic health therapists, particularly if they started in pelvic health primarily or came from anything other than musculoskeletal sports, to consider a broader perspective outside of the pelvic floor?
Right. I think it comes down to training and to recognizing that, yes, the pelvic floor lives in the body and it's attached to the nervous system, the central nervous system. It's attached to the low back and the pelvis and the sacrum. And so there needs to be a commitment for all of us to get out of our silos, right? I am moving away. I haven't taken it off my email tagline yet, but I'm really thinking I'm just going to go back to registered physiotherapist and not pelvic health physiotherapist, which is what I probably switched to about 10 or 15 years ago when I was really kind of doing more and more pelvic health. And at that point, it was about recognizing that we need to start talking about the pelvis. And now enough people are talking about the pelvis. It's still not fantastic. We're still not like across the board where we need to be, but it's so much better than it was a decade ago. It's much more recognized, which is great. And the research has really helped that. And I think just overall the training of pelvic health therapists. But I think we need to stop identifying with that label. I'm a pelvic health therapist. I'm an MSK therapist, right? And I'm a pain science therapist. And I need to look at each one of my patients from an MSK perspective with pelvic health considerations. And I'm blessed, and I would say blessed enough to be able to do internal exams. I can't imagine anymore treating low back and hip pain without being able to assess what's happened in the pelvic floor when appropriate. So I consider that a blessing and a privilege to be able to do that. And it's not going to be everybody's niche, and I recognize that. And it probably shouldn't be everybody's niche, right? But even MSK therapists need to then develop skills within pelvic health, and pelvic health therapists must. I will tell you what my bias is. I'm a McKenzie credentialed therapist. I've been a credentialed therapist since 1999. I think it's a very logical, simple system. McKenzie therapists have to ditch their talk about disc pathology because we don't have a lot of good evidence around that piece. So I think we have to clean up our language. And I think manual therapists also have to clean up their language around some of the terminologies that we use. And if we go back to pelvic girdle pain, this whole pelvic girdle instability piece, we need to really clean up that piece, because there is no such thing as pelvic girdle pain instability unless you have a stress fracture or something that really has gone awry. But, I always say to people, if you're in a car accident, you will never rupture all the ligaments of your SI joint. You will break one of your pelvic bones first before you do that. That's how strong and stable those ligaments are. So we kind of have to all clean up our language. And then we all have to put on our pain science hats. Now, I think in Australia, you guys are better at that than we are here in Canada. As I interact more and more with Australian PTs, I think that overall it has infiltrated into the universities much better than it has here. It's coming, but it's really, really, really slow. And I think the pelvic health therapists here in Canada are probably some of the leading therapists in pain science right now, because we were kind of forced to go there. You can't treat pelvic health and not recognize central sensitization. So we all have to get out of our silos, and we all have to start putting tools in our toolkit that address the whole patient.
So on that note, Carolyn, and I'm very cognizant of the time that we've had you, so I'm just going to ask one more question, and I'm sure Anthony will have another one as well. And but from what I'm hearing from you, to quote my buddy over there, he says that a lot. I love that you've talked about the biopsychosocial approach, and you've talked about all the different influencing factors that can, or many of the factors that can influence someone's pain experience, because it is an experience, and it's like you say, it's an N equals 1. Everybody has a very different story, and there's no recipe that we can throw at people with pelvic pain. But what I'd love for you to tell our audience, and just remembering some people here not health professionals, and we have some fitness professionals, we have some people from the general public, but I'd love for you just to very briefly give a little bit of an overview of what treatment of you can give a patient example if you like, but what it might look like, because I think some people might still have this idea that treating an overactive pelvic floor involves, putting wands in and releasing trigger points, and that might be a small part of it for some people. But if you don't mind just giving a little bit of an overall view of what that management might look like, and the multidisciplinary involvement as well.
Okay. Do you want to take overactive bladder, maybe?
Anything like an example would be great.
Okay, as an example. So if we have someone with overactive bladder, which it just means, for those people who don't really know what that means, that just means that you have urgency, frequency, and perhaps urge incontinence, which just means that instead of just saying, oh, I have to go to the bathroom, your bladder says to you very quickly, I have to go to the bathroom, and you can hardly make it there, or sometimes you leak on the way. Okay, so that's urge incontinence. And urge, like pain, is actually an output of the brain. The brain creates urge, the brain creates pain. And when we recognize that, that means that we really have to look beyond just the bladder. So as a pelvic health therapist with someone with urge incontinence, if you're really taking a biopsychosocial approach and a whole person approach, you want to be using some of the questionnaires. I think there's a lot of great evidence around some of the work that Donna Carrico did in 2008. She was a nurse who looked at the role of mindfulness and meditation in overactive bladder. There was actually a new narrative report that was just done on overactive bladder and central sensitization. So if you are treating someone with overactive bladder, you need to measure central sensitization, because urge is an output. So you should be using a questionnaire like the CSI to measure that. You need to be measuring depression, anxiety, and stress, because those are highly correlated with urge incontinence. And then you need to start with a lumbar spine screen, because again, the nerves that feed the bladder come from the lumbar spine, and you will see upper lumbar and lower lumbar problems that actually create urgency. There was a case series, 2 case series now that have been published from MDT therapists, mechanical diagnosis and therapeutics, so McKenzie approach, that have showed that you can resolve somewhere in the neighborhood of about 56 to 75% of urge incontinence and lower urinary tract symptoms by treating the lumbar spine. So start with the back, right? And then look at what's happening in the pelvic floor. And often what we'll see is too much tension, overactivity in the pelvic floor. But again, when the pelvic floor is overactive, is it really the trigger points that you need to treat, or do you need to teach people how to actually let go of tension in their pelvic floor, and do it dynamically, do it actively? I use a lot of cat-cow, I use a lot of squat with cat-cow and dynamic obturator stretches. Really what we know when there's a lot of central sensitization at play, if we look at the fibromyalgia research, dynamic range of motion exercises are much more effective than static stretches. So again, we should be using much more dynamic movements. If there's a lot of tension in the pelvic floor, look at the central nervous system, right? If there's a lot of stress going on, and they're measuring on the stress scale in the moderate category or higher, think about using things like yoga or qigong, for example, some novel movements to not only open up the pelvic floor, so there's the physical part, but actually to evoke the relaxation response and to calm down the central nervous system. So again, using a very global approach. And then once they have the ability to actually relax their pelvic floor, then you may need to do some time voiding. You may need to do some behavioral changes. Of course, through this whole thing, you may do a bladder diary and just start to look at some of their habits. So you can see how there's all these different components. And never once have I talked about releasing trigger points, right? Because what we know from a nice meta-analysis done by Denny in 2019, who showed globally, but also specifically in pelvic pain, is that releasing trigger points is not an effective solution for changing chronic tension in a muscle. So we need to kind of move away from that thought process. Muscles are tight, but I'm going to say they're more hypersensitive, right? I tend to call it more pressure hyperalgesia at this point than trigger points. Did that kind of answer your question? Yeah, beautiful.
Yeah, for sure. And even with muscles are tight, I tend to say muscles feel tight. I absolutely agree. You feel really tight down there. You know, because sometimes they're not.
Yeah, right. But it's their perception, right? Or they feel stiff,
Absolutely.
right?
Absolutely. It definitely feels
Mm-hmm.
tight. Yeah.
Mm-hmm.
I do want to throw a bomb in here. Um,
Of course you do, Anthony.
Sorry.
That's good.
You know, obviously I don't do internal work, so I often have referral bias where people have had 20 sessions of internal releases, no change. I'm getting lots of different presentations that I don't do internal work for. One of the interesting things that I've been doing for a few years now is treating pelvic organ prolapse less as a structural problem than as a perception of symptoms problem. And I was wondering what your take on dealing with pelvic organ prolapse from a pain science perspective, in terms of could they actually just be feeling sensitization and symptoms, as opposed, because you know there's lots of people with grade 2s and 3s who who don't um, who don't feel the symptoms of
Mm-hmm.
prolapse, and there are people with a grade 1 or a 2 who do. And
Mm-hmm.
you know, Marika has two fantastic videos on YouTube about just the personal experiences. She did a questionnaire, and you know, there seems to be this mismatch of symptoms and pathology, if you want.
Right. Right.
Would love to know your thoughts on
Mm.
that.
I would agree 100%. And I think even if we look at who gets surgery, right? What is the scale for who gets surgery? And to qualify for surgery in Canada really is based on bothersome. It's the bothersomeness of the problem that then, you know, causes someone to go to the surgeon, and for the surgeon to say, okay, this is really bothering you, I will do surgery. Right. So it's not so much that it's a grade 2 or grade 3, it's the fact that it's really bothering them. So that it's a bit like stiffness, right? If we go to the stiffness literature, it's not that those people are actually more stiff than the average patient population. In low back, that has been shown, but the perception of stiffness is there. So again, it's a perceptual issue. So I really think that when it comes to, and again, as pelvic health therapists, we have to own some of this. We have pathologized, right? So we have pathologized pelvic organ prolapse. And we have created a lot of fear, a lot of guarding around how to move and how not to move to make that prolapse worse. So again, this is full disclosure. You know, I've already told you about my trips up and down the basketball court leaking and having to change my pads. I have a full thickness rupture of my right levator ani due to a high forceps delivery for my first baby. And hence I do the work that I currently do. I have a grade 2 prolapse, a cystocele, and I've had that for 31 years. So that's how old my oldest is. And that prolapse has never progressed. I lift heavy rocks. I do lots of heavy work. I don't protect my pelvic floor. And so we as physiotherapists, especially pelvic health therapists, need to watch, again, our language and our beliefs around how fragile we are with a pelvic organ prolapse. And I love your functional approach, Anthony, around getting people moving and confident in their body again. And again, I think this is where measuring some of the distress around prolapse is as important as measuring the distress around pain, because it's the distress that needs to be addressed often, and then guiding them towards function versus the prolapse per se.
Oh, I love that. I actually did a presentation last year at the Women's Health and Fitness Summit. And I think my title was something along the lines of, does language matter when it comes to managing pelvic organ prolapse? And that was predominantly to fitness professionals, but it was very much around, you know, some of the messaging that we give and that vulnerability. And we can really contribute to someone's problem. Or like you said, we can really be part of the solution and offer alternatives and really look at trying to support women to get them back to doing, you know, teach them all the things that they can do right now, not just continuously take things away. You can't do this, you can't do that, this is going to make it worse, and really contribute to that fear presentation, which is huge. fear is massive in prolapse. And, you know, I'll often have a lot of new mums who come in and, you know, they're only 6-8 weeks postnatal. They've got a really small prolapse. And most of the time I'm sort of like, you're doing great.
Right.
Everything is healing really well. Here's what you should do right now. You know, like,
right. Thumbs up.
Yeah, but it's tricky because if they've been on Google and in particular, I find a couple of the Facebook groups that people join with prolapse, and especially, I don't want to name one in particular, but there is one where a lot of women have gone through a lot of surgery, marriage breakdowns, suicides. Like it's quite catastrophic. And I have you know, prolapse as well. I've had 2 vaginal deliveries. I'm asymptomatic. My pelvic health physio, bless her, who after my second, she said, oh yeah, there's a little bit of prolapse in there. And I remember the guy, what? This is before I was working in pelvic health. I went, what? What do you mean I've got prolapse? And she said, oh look, anyone who's had a vaginal delivery will have a small amount of prolapse. You got to strengthen your pelvic floor, you'll be fine. And I was. Then I went and joined this Facebook group as research, just learning a little bit more about what people experience. And I started experiencing symptoms. And Anthony's heard this story, but I remember driving my car on the freeway. I called my husband up in floods of tears and I said, things are coming out of my body. This prolapse is getting worse. And he said, what the hell are you talking about? You were fine a week ago. What has changed? That is what had
very wise. Wow. So yeah, these prolapse groups are not unlike some of these pain groups, right? That again, you know, support groups are well-intentioned and you know, really do try their best to kind of encourage people, but you really have to say, is it a solution-based support group, or is it kind of a bitch-based support group where we're just going there to complain about how tough things are and we want someone to kind of come alongside us and say, yeah, it's really rough, because you got to pick your support groups, and you got to pick your friends, right? Like, I mean, thank goodness for your husband who said, what the heck, like a week ago you were fine, what happened, right? So you picked a good man there.
Beautiful. Thank you for that, because, you know, it seems shocking to pelvic health therapists sometimes to say maybe the prolapse doesn't matter so much, and it's good to hear that from other people. I just like hearing what I like. What I like, you know, confirmation bias.
We love our confirmation biases reinforced.
We all do. We do. Look, it's been fantastic. I know that we could talk for hours. We literally have talked for hours before.
Yes, we have.
Thank you very, very much for being on the podcast. Can you tell us a little bit about how people can find you and what some of your online education offerings are, and where we can find those, please?
Okay, absolutely. Well, thank you both for having me. First of all, Marika, it's lovely to meet you finally.
And you too.
And thanks. And so right now I'm a little bit low profile on social media at this point. I have recently sold my teaching company, Pelvic Health Solutions, back to Nellie, who is running it now on her own, doing a great job. And so that was sort of the main sort of area that you could reach out to me previous to this. So right now I am very much a clinician as well. And so you can reach out to me either by email at carolyn.vandyken@PhysioWorks Muskoka, which is my treating company, .com. So that's one way of reaching out to me. You can probably find me on Facebook, but you'll find me actually very inactive on Facebook. My profile has never really been developed a whole lot. If you want to join a fabulous pelvic health support group of clinicians, you have to be a physiotherapist to join this group. You can join the Pelvic Health Solutions group, and you certainly can interact with me on that closed Facebook group. And in the near future, very near future, I'm hoping to launch a new online teaching company that will look at integrating pain science, pelvic health, and orthopedics, particularly around low back pain, where we really are going to collectively and lining up a fabulous international team right now of instructors that will do live online courses. I'm not a huge, I've put a number of courses out there on Embodia, particularly that are canned, so pre-recorded, but the completion rate of pre-recorded courses is not great. On average, people complete about 10% of the course. And we just don't have enough time to kind of slot that into our day, which seems to be the problem. So I really want to develop more of a live online interactive course venue through Zoom. And so look for that in the near future. And when that's up and ready, I'll let you guys know. How's that?
Sounds beautiful. Sounds perfect. Really appreciate it. And one thing that I forgot to mention at the start, just because I'm a bit tired, to be honest, is that Carolyn has been involved, I would say, I don't know what the percentage is, Carolyn, you might actually know, but it seems like you've educated most of the pelvic health therapists across Canada, with, together with Nellie and Pelvic Health Solutions, and MJ, of course, as well.
Marie-José Lord and Claudia Brown, we were really the original instructors. And then really in Ontario, Nellie and I kind of jumped in about 10 years ago. And so just to give you an example, in Ontario, which is the biggest province in Canada, has the biggest population, we had 5 pelvic floor physiotherapists 10 years ago in 2009. And now we have well over 1,000. So it has exploded.
What?
Yeah, we really have exploded pelvic health in Canada, which has been fabulous. And I would say that
oh my God,
they all have learned pain science. Really implementing pain science would be my next goal, right? And it's a big learning curve for sure.
It's steps, right?
It
and
is.
And I've taught all across Canada, and somebody's taken PHS something level 1, 2, 3.
Yeah.
All the other courses that you've run. So so thank you. Feel very privileged to have you on here. Would love to have you back to talk about anything you like. And if you're listening to the podcast and you have questions for Carolyn, feel free to leave a comment and we'll make sure that we get them to Carolyn. If you'd like to hear from Carolyn more, let us know what you want to hear from Carolyn, or any other topics at all. But otherwise, we'll see you next time on the Women's Health Podcast. Thanks very much.
Thanks, Carolyn.
Thanks, both of you.
Well, that's it for this episode. Be sure to hit like if you enjoyed the episode and leave any comments or questions below. We'd really like to hear from you.
If you haven't already hit subscribe, please do so now so that you can be kept notified when we release our next episode.
Otherwise, thank you for listening, and we look forward to having you back with us for another episode of the Women's Health Podcast.